Okay, I think we can begin now. So good morning, good afternoon, and good evening to all our participants today from all time zones. So first, I would like to welcome you to Tokyo College's online symposium at the age of pandemics, contextualizing cleanliness and hygiene in the past and present. Day 2, my name is Hongying Tsai, and I am a postdoctoral fellow at Tokyo College, the University of Tokyo, and I am the meeting host of this event today. So in the previous section last week, we reviewed the religion's origin of cleanliness and hygiene and how it became the current scientific hygiene in the history. We also explored the history of public health that American medicine and German medicine models travel and localized to Japan. And we also contextualized clinical trial of vaccine from the global perspective, in which people in developing country take higher risk of being the experiment subject, but get less benefit from the knowledge and the result of this clinical trial. And today we will explore the contemporary challenge of clinic and hygiene and public health and see anything we can do for a better future hygiene. I would like to take a moment to introduce our speakers today. We are glad to have Dr. Tsai-Yen Han. Hello, welcome. She is a postdoctoral research fellow in the National Academy of Education Research in Taiwan. And we have Professor Masaomi NANGAKU. He is a MD, PhD, Vice Dean Professor and the head of Division of Nephrology and Endocrinology at the University of Tokyo Graduate School of Medicine. Welcome. And we have Dr. Rebecca J. Hester. She is the Associate Professor in the Department of Science, Technology, and Society, the Association Director of Education in the Center of Refugee, Migrant, and Displacement Study at Virginia Tech in the United States. Welcome. Hi. Okay, before we start our presentations today, I have some housekeeping announcement for all participants. If you have any question or comment, please submit them using the Q&A function on the Zoom screen down below. We will collect and respond there to all the questions when we finish all the presentations today. And if you need to switch the language, please use the interpretation button. Also on the screen down below, you can switch from English and Japanese. Okay, so we will start with Dr. Han's presentation. Dr. Han, please.
All right, let me share my screen now. All right, can you see that?
Yes, we can see it perfectly.
All right. Okay, then I will start my presentation today. So good morning, good afternoon, good evening, everyone. I'm Tsai-Yen Han, a postdoc research fellow at National Academy for Educational Research in Taiwan. Thank you for having me on this panel. I'm honored and excited to share my research with you. Today, I will discuss the mothers' childcare practices on hygiene based on the interview data of mothers currently raising infants, toddlers, and preschool-age children in the United States. Especially, my talk will center on what mothers feel they are expected to do under modern medical discourses on child hygiene. So my presentation topic is scientific motherhood, cleanliness, and contested hygiene discourses on childcare practice. So as you know, or you may not know, if you have kids, you will know like dealing with dirt is a common task that mothers and caregivers routinely encounter in daily care for infants, toddlers, and preschoolers. It includes changing diapers, cleaning hands, sanitizing items children use, and deciding how often to bath children, where children can crawl, how to feed them, and whether they can play with dirt or dig in the ground at what age. So social norms, cultural expectations, and medical discourses shape what constitutes a dirty child or a clean one. Therefore, mothers in different societies, different cultural backgrounds, and different socioeconomic status who believe in different medical discourses will have different ways of dealing with dirt when caring for their young children. So you may observe that some mothers wipe their children's face and clean their hands every 5 minutes, while some encourage their children to play with dirt. As you can see, some mothers feed their children and encourage their children to use their fingers when they eat. Some mothers, they change their diapers in the forest. And some mothers, they try to sanitize all the toys and the equipment their children use, or some mothers even encourage their children to crawl on the ground. So there are different ways of dealing with child hygiene when they raise young kids. So the traditional society, mothers-to-be or novice mothers learn how to be good mothers from their mothers, their relatives, or elders. However, in modern society, medical and scientific knowledge gradually replaces the legacy of traditional elders. So scientific knowledge, doctor's advice, and medical health education have become the most crucial learning sources of accurate information and expertise in contemporary mothering experiences. So studies have pointed out that in modern societies, mothers are expected to perform scientific motherhood. That means a good mother should actively learn the latest scientific knowledge and accurately care for their children. A good mother should be able to soothe, raise, care for, and nurture her children with the proper pediatric knowledge. A mother should take responsibility to ensure that her children develop well and thrive. If her children have any health issues, it's a mother's responsibility to seek advice, not from their mothers or elders or friends, but from medical experts to ensure they are healthy and grow and develop soundly. So as we can see, in the modern society now, mothers are expected to seek for medical and scientific advices like from doctors. So what does that doing to the practice of mothers? But under this scientific motherhood, we have these mainstream discourses on good mothers. Based on these scientific motherhood discourses, there are many mainstream discourses on good mothers and child hygiene. For example, good mothers are expected to use scientific knowledge and make intensive efforts to protect their children from exposure to various types of dirt, including virus, bacteria, toxins, and chemicals. Mainstream discourses on mothering expect mothers to keep the house and children clean. It includes constant tidying up, sanitizing, disinfecting places, equipment, objects children will use and touch, patiently and gently cleaning, wiping and washing young children's body, and keeping children away from exposure to infectious germs. So most mothers feel that they are expected to clean from the morning to the night to fulfill these expectations. Mothers need to clean the kitchen, the bedroom, the entire house, wash the dishes, do the laundry, vacuum, mop the floor, sanitize the bottles, toys, and other feeding equipment. Mother's work is never done, because the young children are messy eaters and constantly need mother's care and help to stay clean. So as you can see, a lot of mothers, they constantly keep cleaning, keep sanitizing, keep doing this and doing that because they are expected to do so, to be a good mothers, to protect their children from exposures to the germs. However, the interesting thing is that our understandings of cleanliness and dirt is overrooted in scientific knowledge and research. But why are there different mothering recommendations on child hygiene? For example, some mothers, they encourage their kids to play with dirt, others don't. So if different suggestions are all from scientific research findings, which scientific knowledge is correct in what situation? So to answer this question, we need to know that scientific knowledge and medical discourses are not static, but dynamic. They are always in a competing process. So different medical discourses identify different kinds of dirt that cause disease, provide different ways to prevent sickness, and offer different suggestions to stay healthy. Therefore, we may have different suggestions regarding trial hygiene. So what's the two main theoretical perspectives on trial hygiene and germs? So they provide different suggestions on trial hygiene for mothers. So the first one is the germ theory. It suggests that mothers should create a clean and hygienic environment to keep children clean and hygienic, to pay attention to disinfections and sterilizations, and ensure that children will not get sick from exposure to germs. However, we also have another one. The other one is the hygiene hypothesis, or we call the old friends theory. It suggests that mothers should lower their hygiene standards and allow their children to be in touch with nature as much as possible, play in sand, dig mud, eat soil, and chew on leaves. It recommends mother increases the chance of exposure to microorganisms to reduce the risk of future allergies. So these two different sets of suggestions on trial hygiene are based on two different medical understandings of dirt and disease. They have different conceptualizations of dirt, perceptions of cleanliness, and strategy to fight disease and achieve health. So the germ theory promoted by traditional epidemiologists and public experts, health experts, emphasize cleaning and hygiene. The germ theory states that contact with germ is the cause of disease. Dirt and dust are carriers that germs will harbor. Therefore, not only germs, but also dirt is the threat to health. In this paradigm of germ theory, germs are harmful to children's health. When children are exposed to germs, it increases their risk of getting sick. Therefore, cleanliness and hygiene are essential for mothers to protect their children's health. In short, mothers should kill and reduce exposure to germs, and that's the best way to prevent infections and disease. Furthermore, germs are everywhere, so to ensure that children are not exposed to germs and grow up healthy, a good mother must always clean, disinfect, sterilize. For example, sterilize everything the baby or a child will touch. However, we also have these relative alternative ideas on child hygiene, but the hygiene hypothesis or old friends hypothesis. That's supported by many microbiologists who argue that children should play with dirt. These hygiene hypothesis rise in 1989 posed a challenge to dominant hygiene norms and ideas based on germ theory. So the immunologists and the microbiologists questioned the connection between cleanliness and health and begin to promote this idea, the new trial rearing principle, embracing the dirt. So these experts suggest mothers let children get dirty and play in mud. They argue that not contacting germs is the cause of disease. So dirt will not cause disease. Allowing children to touch dirt, play with dirt, and eat dirt increases the diverse microbial exposures. And it will help children build a more diverse microbiome in their gut to regulate their immunity and lead to a better health outcome when they grow up. So as we can see, we have these two different ideas on child hygiene, on our relationship between the germs and the child health. So they also have different suggestions. So for example, based on the germ theory, the CDC, the Center Disease Control and Prevention, suggests public to fight germs, wash your hands. So what you should do is you need to wash your hands, and that's the best way to remove germs, avoid getting sick, and prevent the spread of germs to others. No matter where mothers and children are, keeping hands clean is one of the most critical steps a mother can take to protect their children from germs that can make them sick. So regularly wash children's hands or using hand sanitizer when soap and water are readily available helps us to keep children healthy. On the other hand, we also have this old-friend hygiene hypothesis. They expect mothers to encourage their children to play with dirt, to have diverse exposures to microorganisms. You see, if you have your children have a dirty hands, that means they have great exposures to the microorganisms. That's good for their health. So there are microorganisms that our body should ideally know to tolerate. But because of a lack of exposure to them in early childhood, our body thinks they are a threat to us and overreact to their presence. So as Sally Bluefield says, it's not only about learning what to attack, but learning what to tolerate. So early exposure to friendly microorganisms and germs will help children regulate their immune system and help them develop a tolerance to environmental components such as pollen, mites, dogs, and farm animals. As you can see here, different theoretical perspectives, they have different suggestions. While one emphasizes on sterilizing everything like feeding bottles, the other one encourages mothers or caregivers to encourage their kids to play with dirt and to get dirty and to get those exposures. All right, so then we will have these questions. So under these different ideas about child hygiene and about the way to raise their children, what the mothers and caregivers will do, play with dirt or not. So I found the interesting thing is the social class matters. So who will let children playing with dirt? So middle-class parents have a higher tolerance for dirt exposure and encourage their children to embrace nature and to play with dirt, make mud pie, digging ground for the earthworms, and get dirty. These middle-class families usually live in good neighborhood with plenty green spaces, well-maintained parks, trails, recreation facilities, and no environmental hazards. So they encourage their children to explore in nature and to have fun. On the other hand, I also noticed that the working class parents, they promote the values of cleanliness and hygiene with the belief that it could keep children away from the threat of germs and disease. So they don't want their children to get sick because many of them don't have enough sick leaves and are not able to bring their children to see doctors when they are working. So many working families, they live in a neighborhood called nature deprived with limited or even no access to green spaces, and their parks are dirty and poorly maintained. Sometimes they have trash, cigarette butts, or dog poops. So they worry about what would be underneath the grass and sand when their kids play with dirt. So the parental practice on child hygiene are not only reflect on their understandings of scientific knowledge, but also associated with their social class. With limited coverage on insurance and benefits, many working class parents prefer to keep their children away from dirt. On the other hand, we can observe that middle class parents with better insurance and benefits promote these ideas of playing dirt. Furthermore, with this unequal access to local well-maintained green space in the neighborhood, parents from different social class, they use different strategies to keep their children healthy. So from my presentation, we can see that the idea, the simple question, will you let your kid play with dirt, actually situated in what kind of scientific knowledge and what kind of social class the parents are situated in the society, right? That's all about my presentation. Thank you, and looking for the question and the great discussion with you all. Thanks.
Thank you so much for this amazing talk. For all our participants, if you have any question or comments, please feel free to submit using the Q&A function. We will collect it and respond it to all the questions after the 3 presentations today. And next we'll have Professor NANGAKU. NANGAKU Sensei, would you like to start your presentation?
Yes, thank you very much for your introduction. I am Masaomi NANGAKU, Vice Dean of the University of Tokyo Graduate School of Medicine.
Sorry to interrupt you. Dr. Han, could you please stop sharing your slides? Yes, that's nice. Yes, sorry, NANGAKU Sensei, please.
So is it on?
Yes, it's okay.
Good.
We can see your slides now.
Good. I'm also serving as the President-elect of the International Society of Nephrology, immediate past President of the Asian Pacific Society of Nephrology, and the current President of the Japanese Society of Nephrology. So I am going to give a talk from a standpoint of a nephrologist, a doctor of kidney disease. I have nothing to disclose about my conflict of interest. This is the current status of kidney disease. All over the world, 850 million people are suffering from kidney disease, and 2.6 million people receive dialysis or transplantation due to end-stage kidney disease. Kidney disease will be the 5th cause of death by 2040. And even though they can enjoy their life if they receive dialysis or transplantation due to end-stage kidney disease, they are immune compromised and are susceptible to infection. In Japan, 13 million patients of chronic kidney disease are now, the number of the chronic kidney disease patients is 13 million, and that of end-stage kidney disease dialysis patients is 340,000. They go to dialysis clinic every 2 days. They get treatment of dialysis for usually 4 hours, and the beds are very close to each other. So when one gets infection such as COVID-19, others in the same clinic may be susceptible to the spread of the infection. So we are paying a lot of attention to prevent the outbreak of COVID-19 in dialysis patients. As I said, patients with end-stage kidney disease are immune compromised, and they are easily infected by various organisms, including COVID-19 infection. The serologic screening of the patients of hemodialysis in United States confirmed that there are many asymptomatic COVID-19 infection in hemodialysis patients. We developed the infection control of COVID-19 at dialysis facilities. Those who work at the dialysis centers wear face shields, facial masks, gowns, and gloves. We pay a lot of attention to prevent the outbreak of COVID-19 at dialysis facilities. If one gets infected with COVID-19, originally our government required that all the patients should stay in the hospital, but it was not possible because the number of the patients with COVID-19 became too many. So what we did was to isolate patients, spatial isolation. We have to put the COVID-19 infected patients far from other patients if possible. And we also do temporal isolation. In some cases, dialysis clinics opened their clinics on Sunday just for one COVID-19 patient. So because of they had to do temporal isolation. The Japanese Association of Dialysis Physicians, the Japanese Society for Dialysis Therapy, and the Japanese Society of Nephrology developed the COVID-19 Task Force Committee, and I joined this as the representative of the Japanese Society of Nephrology. And we published a lot of analysis of the Japanese status of COVID-19 infection in patients with kidney disease. We also published the COVID-19 expert opinion from the Japanese Medical Science Federation. The Japanese Medical Science Federation is composed of more than 140 academic medical societies. And this expert opinion covers all the aspects of COVID-19. This shows the status of COVID-19 in dialysis facilities. Overall survival was relatively poor compared with the general population, and the survival was even worse in the elderly with dialysis patients. Vaccine is effective because patients with end-stage kidney disease are immune compromised. They do not get high titer of antibody induced by vaccine. However, as you can see, unvaccinated patients showed much poorer survival compared with the patients who got vaccination but had breakthrough infection. So obviously, vaccination is effective even in immune-compromised patients. We also surveyed the shortage of personal protective equipment for medical staffs. During the pandemic, many facilities complained about shortage of disposable gloves, disposable masks, and so on. So what was the hurdle or barrier for isolation measures in dialysis facilities? The most important barrier for isolation was separation using a private room, because many clinics do not have a private room for dialysis. So separation of space is difficult in Japan. This is an interesting analysis performed by Dr. Yamaguchi under the leadership of Professor Kadowaki, now at Toranomon Hospital. They checked the status of healthcare service for COVID-19 patients in Japan, for non-COVID-19 patients in Japan. So if the measures, healthcare services, are not emergent or mandatory, it decreased, like endoscopic fibroscopy, prostate biopsies, or rehabilitation. But for hemodialysis, if you do not get hemodialysis, you will die. So there was no change in healthcare service for hemodialysis. The same was for chemotherapy of cancer. They did completely the same way of chemotherapy treatment during the pandemic for non-COVID-19 patients. Impact of the COVID-19 pandemic on the kidney community, what we learned and what we should do in the future. There were many challenges, including interruption of new consultations and follow-up care, and so on. So one of the important major solution is to adopt telemedicine. In China, they put this 1-minute clinic something like a telephone box. If one enters this 1-minute clinic, he or she can get telemedicine consultation every day, 24 hours a day. And they can even get drugs at the box from the next to this 1-minute clinic. So the government of the United States made a very brave movement to promote telemedicine, and it is now common in the United States. Unfortunately, telemedicine is still uncommon in Japan for various reasons. This is an important issue we have to solve in the future. In addition to telemedicine, another issue we have to solve is the exclusion of the patients from clinical trials. To treat patients in an appropriate manner, we need evidence from clinical trials. But those who run clinical trials want healthy, relatively healthy patients because they think if they recruit sick patients, the trials may fail. So CKD, chronic kidney disease, is included as the exclusion criteria in many clinical trials. We need to confirm the effectiveness of various treatments in clinical trials of CKD patients. Last but not least, scientific information is very important. Dr. Han emphasized that good mothers use scientific knowledge. In addition to good mothers, good citizens should use scientific knowledge in an appropriate manner. This book, Preventing the Next Pandemic, picked up the factors to aggravate the pandemic. That included poverty, urbanization, climate change, and anti-science. Anti-science, people with anti-science insist that vaccines do not work or even harmful. The WHO warns about this kind of infodemic. In addition to the pandemic, there are many disasters, such as earthquakes and war. In these cases, hygienes are also important, and these disasters may attack us anytime. So we have to get prepared. This is my last slide. The Japanese Association of Medical Sciences will hold the meeting in April next year. And this meeting is also open to the citizens. We invited Anthony Fauci, Audrey Tan, and Dr. Omi, and so on. We will discuss about the pandemic in detail. So please join this meeting as well. Thank you for your attention.
Thank you so much, Professor NANGAKU. If you for all the participants, once again, if you have any question or comment, please feel free to submit using the Q&A function. If you would like to switch the language, please use the interpretation button on the screen down below. Next, we will have Professor HESTER. Yes, we can see your slide, please.
Okay. Thank you so much for inviting me on this panel. Thank you, Hong-Yin, so much for having me tonight. The title of my talk is Pathogenic Entanglements, the Inflammatory Politics of COVID-19. And this talk in general is about two things. One is that it's about competing scientific narratives around the origin and distribution of COVID-19. And the other is about a kind of longer history of nation states trying to clean the body politic with political and medical kinds of interventions. So this idea about pathogenic entanglements came about as I was watching the pandemic unfold in the United States, and specifically looking at the fact that many racialized populations, as you see here, Native Americans, Hispanics, and Blacks, were among those who were dying at the highest rates within the United States. And it was a lot of middle-aged people. It wasn't the traditional folks that we thought it would be, that is the immunocompromised, elderly, and the young. It tended toward a surprising number of racialized folks in their, what we would consider to be their healthiest years. So there were a couple of, there was quite a lot of hand-wringing about how to account for these deaths. There were a lot of questions within the scientific community and within the media about how to classify the origin and the kind of the disease that people were suffering from, especially early on in the pandemic. There was some questions about the kinds of exposures that people had had, whether it was in the communities of origin in China or throughout the different countries of the world, that made certain bodies susceptible to illness and early death. And then, of course, the big question was what to do about it. Where do we focus our health interventions? So I argue here that these, this kind of hand-wringing, these debates about how to account for these, what they call excess deaths in public health, all kind of operated from a similar epidemiological style of reasoning. And within this kind of style of reasoning, the focus was on the three predominant aspects that epidemiology is focused on, which is the incidence of the disease, where did it happen, where did it emerge, the distribution, and then the control. And this style of reasoning also has a very heavy emphasis on prevention and preemptive action, and is pervasive across different disciplines. So it's not unique to public health. Biomedicine was also quite interested in this. Global health security and folks in biosecurity were also operating from this more epidemiological style of reasoning, which is the dominant way of responding to an infectious disease outbreak. And one of the things that I noted, having read Priscilla Wald's wonderful book, Contagious, which I have an image of here, is that this kind of style of reasoning was couched in what Wald calls a formulaic story about disease emergence. It's one that is well rehearsed within the media, but also within popular culture. You can see this in films, but also within the scientific literature. And the formulaic plot goes a bit like this. There's an index case in a foreign land that's not a Western nation. It's the infection is transmitted by humans through travel and commerce. It's often characterized by fear and crisis. And as Wald points out in her discussion, and as we can see in popular media and films like Outbreak or World War Z, there's a kind of dual response. One is military and the other is medical, but they're focused predominantly on containment and the development of medical countermeasures. So certainly this sort of formulaic aspect or narrative of infectious disease was at work within COVID-19, right? So from the United States perspective, what we saw was the origin or the incidence was bats in a wet market, although there was some contestation around whether it had actually been a laboratory leak. But either way, the origin happened in Wuhan, China. That was the emergence. Then it was distributed through trade and travel. Of course, Wuhan has a huge port there, and much was made about the fact that from that port, COVID-19 was spread, but also through air travel, as many in the public health community have warned that an infectious disease can get anywhere in the world in less than 24 hours through air travel. And then the third piece of this plot as it unfolded was that we should prevent travel and human contact through quarantines and masks. And of course, we should develop and distribute medical countermeasures. So altogether, this kind of narrative about what we would expect with an infectious disease played out with COVID-19, as it did with SARS, as it did with swine flu. We've seen it over and over across time and space. And Wald points our attention to the consequences of telling this same kind of epidemiological story about infectious disease. For her, these words and these stories have consequences, and in fact, they have life and death consequences. As she writes, as they disseminate information, that is the media and the scientific community, about the infectious disease, they affect survival rates and contagion routes. So there's an actual real world implication for how we understand, and we all saw this play out with COVID-19, how we understand not only where the virus is traveling, but who is making it travel. And so Wald goes on to say that these narratives, this outbreak narrative, promotes or mitigates the stigmatizing of individuals, groups, populations, locales, behaviors and lifestyles, and they change economies. And we certainly saw this as countries prohibited people from coming into their ports or kept them quarantined at hotels when they're just off the airplane. We saw economies, and we're still seeing the result of the economic effects of COVID-19. And so as we talk about the index case and the travels of different populations who may be infected, we can see that it's not just about science or medicine, but it's also about the social, political, and economic aspects of an infectious disease, and that these have real world consequences for people. And so one of the things that I would argue that characterizes the outbreak narrative, and the outbreak narrative standing in kind of as this larger epidemiological story about the emergence and dissemination of infectious disease, is that there's boundary making work that's happening. And those boundaries are drawn between what Mary Douglas calls purity and danger, right? There's a protectionist kind of aspect that happens around the national body politic, that there's fears of contamination by the foreigner or the outsider, which happens very often and is centuries old with regard to immigrants and foreigners. And so the outbreak narrative with regard to these boundaries reinforces efforts to protect individuals and the body politic from contamination. This is why it's not just a medical issue, but also a military one. So we protect our individual bodies, but we're also trying to protect the body of the nation state. And there's a stigmatization not just of foreigners, but of people who get sick and die, specifically around questions of responsibility and hygiene, that they haven't taken care of themselves, that they haven't washed their hands, that they didn't do all of the things, they didn't wear a mask. And then there's, as I said, the need to defend against contamination with the strongest forces at our disposal. And in this case, it's medical science, but often the military, which has very strong medical science around medical countermeasures and vaccines. So as I watched this unfold, I was thinking about other kinds of frames or narratives that we could tell about the pandemic and about COVID-19. So one thing I want to say is that I do conclude that our efforts to reinforce boundaries between the biologically pure and the biologically dangerous or infected are contributing to the illness and death they're meant to mitigate. And I know that that sounds paradoxical, but in telling an alternative narrative, we'll see how some of these ideas about who's at fault and who's impure actually contribute to the dynamics that make people sick. And the other argument I want to make is that we are all already entangled biologically, and our susceptibilities and exposures because of those prior entanglements predate the emergence of COVID-19. So the idea of always looking for an index case, I think, is a bit wrong-headed, because we have to pay attention to what some scholars in public health would call the upstream factors, not just where it emerges, but what makes bodies susceptible and what kinds of exposures have they had prior to the exposure to the virus. So the framework that I'm using to think about this is one of pathogenic entanglements. And the idea of pathogenesis refers to the development of a disease and all of the chain of events leading to that disease. So for me, what I'm really focused on here is the link in the chain of events leading to morbidity and mortality, or the excess death of racialized minorities in the United States during the pandemic. Perhaps even the chain itself, not just links, are the entangled histories of inflammation, including here an inflamed environment. And you can see the photograph here of wildfires, but also refineries, places where they're burning coal, and there's heavy pollution and fine particulate matter in the air. Incendiary racial dynamics. Here we see folks protesting the murder of George Floyd, but that's not unique in the United States. These are longstanding incendiary political and racial dynamics, especially under the former administration. They were really heightened. And then embodied inflammation that is a sort of precursor to chronic disease. So together, I want to argue that these kinds of inflammatory dynamics, what I'm going to refer broadly a little bit, expanding the term, as I'm going to refer to them as chronic systemic inflammation. So what we get is some evidence that what's going on in the world around chronic diseases and the infectious diseases that people are suffering from, I would argue, has to do with this chronic systemic inflammation that primes bodies, right? That isn't just about what happens inside one's skin, but it's about what happens in the world, so that when there is an outbreak or an emergence, what's actually happening is that the virus is exploiting ongoing dynamics that are both social and physiological or physical, right? And here, a sort of short definition of inflammation. We know that, broadly writ, it's white blood attacking and defending the body from inflammation. And this is actually part of the healing process. But as we saw with COVID-19, this inflammation can go into overdrive. And then, they undergird many of the chronic diseases, as I said, that were contributing factors to who died and who lived with COVID-19. So my argument here is that chronic systemic inflammation is not only something that happens in the body, it happens to and between bodies. So I'm thinking in terms of the planetary body with climate change, environmental racism. I'm also thinking about social bodies with racial dynamics and chronic stress that certain populations like Indigenous folks, Native Americans, Blacks, and Latinx populations in the United States deal with regularly, and individual bodies. And this inflammation, I want to argue, is shaped by power inequities and a political economic system called racial capitalism, or what Paul Farmer, medical anthropologist and physician Paul Farmer, calls pathologies of power. And I want to draw connections between global climate change, production of fossil fuels, polarized and anti-democratic politics, racism and xenophobia, and what happens in people's bodies. So in a way, the kind of suffocation that George Floyd experienced, or that people who died of COVID-19 experienced, or the ways that people who are tear gassed for protesting experience, for me, is also a way of talking about a politics that's suffocating us and that is driving this chronic systemic inflammation. The theoretical underpinnings, if anyone's interested in kind of where I'm drawing from the concept of sort of biosocial conception of health and an ecosocial conception of health. So not something that starts within the body or ends at the skin, but always in a dynamic interaction between bodies and their environments. So there are two case studies, and I'm happy to talk more about these in the Q&A, but that I'm drawing from. One is the Navajo Nation that was hit the hardest in the United States. And as you can see from this article in The Guardian, they talk about the Navajo Nation suffered from twin threats, wildfires, and the pandemic. And so, of course, it wasn't just what was going on in the environment and the virus, but as you see on the bottom right, this Atlantic article that says disease has never been just disease for Native Americans. Indeed, there's a longer history of racism and genocide. And this article here, the scientific article, talks about the epigenome and the transgenerational effects of racism in the body. So bodies are primed and susceptible with chronic systemic inflammation, and their bodies overloaded prior to ever making contact with the virus. And this is what I want to sort of point to, that the outbreak narrative doesn't account for this, these kinds of historical inflammatory dynamics. And so what you would see then is, on one side, the outbreak narrative would tell us that infectious disease is a security or military or medical problem, but a reframe will tell us that it's a socio-political problem. And instead of trying to predict and preempt the future, which is what much of global health security and biosecurity public health is trying to do with syndromic surveillance and other kinds of tabletop exercises and scenarios where they're trying to determine where the infectious disease might emerge or go next, I argue that a sort of inflammatory or biosocial perspective has us looking at the past. And rather than fostering fear and racism of strangers, right, operating from that more xenophobic aspect, actually what we see then in a more biosocial or ecosocial approach is that we would blame fear and racism for already priming particular bodies and making them already in a state of chronic stress. that then undergirds their susceptibility to disease. And then finally, one thing that I have a problem with in the more epidemiological or outbreak narrative focus is that it assumes that all bodies are equally susceptible, right? So everyone wears masks, everyone has to wash hands, and certainly I'm not anti-science in any of those ways. I'm very pro all of those activities. But I think that we do need to pay particular attention so that we're not caught off guard when populations that we wouldn't expect are dying at such high rates. So we have to examine these historical dynamics and these social dynamics to understand what makes particular populations or people susceptible, more susceptible than others. And a similar case can be made about African Americans in Cancer Alley, and I'll just briefly touch on this. But what you see here again is that within Cancer Alley, populations that were historically slaves then stayed in these geographical areas, and then refineries were built up around them in a classic environmental racism kind of dynamic. And then those folks end up with chronic systemic inflammation. And so there's all kinds of things that have been written about the relationship between environmental justice issues, racial dynamics, and then of course, they had very high rates of COVID-19 deaths as well. So these things coming together and combining tell us a different story about how we should understand disease emergence, transmission, and all of the dynamics of infectious disease. And also the kind of predictive lens that we could have. We could almost predict who would die when we take this kind of a lens. So what we get then is that plenty of studies have shown us that racial discrimination triggers an inflammatory response among African Americans at the cellular level. So this is what medical anthropologist Clarence Gravely calls the ways that race becomes biology. So these kind of external dynamics prime particular bodies and then actually have effects at the cellular and molecular level that then make them more susceptible for the kinds of cytokine storms that we saw with COVID-19. And I'm not there yet, but one of the things that I'm looking at actually is how it is that Wuhan itself was also in a kind of inflammatory dynamic. So this is a kind of further aspect of my research, but you can see it's very poor air quality because of the port. And then there was already significant inequality in Wuhan. So the conditions were right, not for someone to eat a bat in a wet market, but for this kind of transmission and the spread of COVID-19 infectious disease. So I just want to finish with this, that inflammation is not all bad. As I said, it has healing properties. And so this is why, in some ways, this project is also about democracy, because when people are pushing back against the conditions that are making them sick, that are making them susceptible to dying at higher rates, then that's also an inflammatory dynamic, which is a healing dynamic, right? So you see lots of protests here, women in Louisiana who are contesting the refineries. And here's a march against Death Alley, which is another way of talking about Cancer Alley. So the take-home points, and I'll finish here, is that the outbreak narrative as a stand-in kind of for the traditional epidemiological story and its reliance on purity and danger, I argue, reinforces the inflammatory dynamics that are making people sick. And that our failure to recognize the ways that we're always already biologically entangled with our world and each other exacerbates these harmful dynamics. So if we're not looking upstream, if we're not looking outside of the body, if we're not thinking dynamically about interactions, we'll miss some of the important information that we need to be able to understand where the virus will spread and who will die from it. And then finally, focusing on the pathogenic entanglements that drive chronic systemic inflammation, and in that broader way, understanding of it offers important social and scientific insights into disease emergence, transmission, and control. But while unlike the outbreak narrative, it also foregrounds racial justice. So I'll stop there. Thanks so much.